Hello, everyone, and welcome back to the FSAP MSc YouTube channel. My name is Manuel Tarango, and I'm the current FSAP Medical Student Council Chair. Thank you for joining us in our next installment of the Meet the PD series. Today, we're super excited to feature Dr. Clayton, the Program Director of the Florida Atlantic University Emergency Medicine Residency Program. We hope this conversation provides valuable insight into FAU's training environment, educational philosophy, and the opportunities available for students interested in emergency medicine. All right, Dr. Clayton, would you like to introduce yourself?
Sure. My name is Lisa Clayton, and I am the program director for the emergency medicine residency here at Florida Atlantic. We are a 3-year program, a hybrid of community and academics, since we're tied to the medical school. And the medical school itself is located in Boca Raton, Florida, and our sites are located in Boynton Beach, Delray Beach, and West Palm Beach.
All right, sounds like a great training environment. So before we go ahead and move into all the fun questions about your program, I like to start with an icebreaker. And here we go. What would you have chosen as a career if you were not in medicine?
All right, so that one's easy for me. I originally went to college to play basketball, and so I was not at all thinking medicine, and my aspirations were definitely more geared towards the WNBA. So I had a career-ending injury that kind of squashed those hopes and dreams, although I'm not certain I would have made it that far, but that is what I see myself doing in a different life.
Okay, so next time your guys' program does an intramural basketball game, you're getting drafted first, is what I'm hearing.
Well, if I play one-handed, the odds are still good that I'm decent, but only one-handed.
I like it. Okay, so Dr. Clayton, what does a successful resident at your program look like?
Okay, so a successful resident in our program is twofold. So somebody who shows up willing to put in the work. So I really appreciate hard work. I really appreciate realizing that 3 years is a very short period of time to learn how to be an emergency medicine doctor. And so realizing that you have to be the one to put in a lot of effort will make you successful in our program. The other piece of things that'll make you successful is just being willing and able to be part of a community. And so we have a really small, tight knit community here in our residency program. It extends to our extended family of nurses and techs and everybody who works in our departments. And so being an active member of that community is really going to help lead to your success here in our program.
Wow, it sounds like you guys are really tight knit, and I know that's something a lot of students look forward to as well. So, what would you say when you're looking for a candidate for the students applying for away rotations? What are you looking at on the VSLOs?
Um, so I'm looking for somebody who legitimately wants to come and spend time at our program and learn more about it. So it's really your reasoning for choosing our site for an audition rotation that I spend the most time looking at. And it's because I want you to be eyes wide open when you're choosing our program. We are a small program, and I want you to realize, you know, or want to explore what that means. We are community academic. I want you to know that and understand and try to give a reason for why you want to spend a month with us. So I just really want you to have done your homework and then chosen us, um, knowing what you know about the program.
So, speaking about the community title that your program has, what can you tell us about the patient population that your hospital typically serves?
Okay, so we're pretty interesting because we have 3 sites. Two of our 3 sites are level 1 trauma centers, and they're the only level 1 trauma centers in all of Palm Beach County. And so, with that comes a unique and interesting patient population. So, I'll start with those first. St. Mary's is one of our sites. And the way I like to describe St. Mary's is is it's a bit of a county feel, but with a little bit more resources than a traditional county hospital. It's a safety net hospital where 2/3 of the patient population are uninsured um, or underinsured. And so you mix that with a Delray. Delray is more of what I thought I was getting into when I moved to South Florida. Like when I moved down here, everybody thought that I was going to be a geriatrician and that I would only see patients over the age of 80. And that is a little bit more of what you get at Delray. So Delray is a level one trauma center as well, but it's a more affluent population. It's an elderly population. You have a psychiatric hospital attached to it, so you get the psych emergency department with it. Um, and then to round it out, we have Bethesda. Bethesda is very much your traditional community hospital where you don't have folks upstairs like waiting to come down to do procedures or consults or your reductions. Like you're doing it all on your own. That patient population is a really nice mix where it's about half uninsured or Medicaid, half insured. The average age of the patient coming through there is around 50 years old. So you kind of get, it's very interesting. If you've never been to South Florida, you probably don't understand, but you drive 20 minutes and it's like you're in a whole new universe, like where the patient population is incredibly different. So even though the patient populations are very different, these hospitals are only a 20-minute drive from one another.
Wow, that sounds like, you have a variety in your training. And as someone that's currently living in West Palm, I can attest to that. You drive 20 minutes either direction, you're feeling like you're in a different state sometimes.
Yeah. Yeah.
So, Dr. Clayton, along with that and the three hospitals your program trains at, can you describe the progression of responsibility for residents over the course of their training?
Sure. So we probably do something that's a little bit different than traditional models. And what we do is a very personalized mentorship, a very personalized individual pathway. And so I can't say that PGY1s can do X, Y, and Z and PGY2s can do this. If you come in day one and you're ready to do something, then we're going to let you do it, whatever training level, that you are at the time. My threes are definitely, running the department and doing all the things a three should be doing, but you might hit that ability year two. And I don't want to like put you in a box just because of your PGY level. And so we do what we call just like meeting you where you are and constantly pushing you. And so the fact that we're such a small program, it allows me to strategically schedule my residents in a way that I've identified some of the areas where I want them to work and that I get to push them in those areas on a regular basis. And so I guess the way to answer your question more generally is it depends on the individual. Your responsibility may accelerate from day one very quickly, or it may take you a little bit longer to get to where you need to get to, but everybody will get there eventually. It's just we don't believe in like putting people into boxes because it doesn't do well for ensuring that that individual is reaching their potential.
That individualized approach sounds like an ideal training situation for many people. So that's great. And like you said, the community practice, being the level one, being able to move them between the three hospitals and still having that all seeing eye and Dr. Clayton to make sure that you hit your potential. That sounds like a great learning experience. So, kind of building off of that, how do you do feedback with your residents?
Sure, we get this is, I think, an important question because um, if you come here or if you're thinking about coming here, you're going to have to realize that feedback is something that is given very readily. So you have to be comfortable with receiving it. And I know everybody thinks that they probably are until it gets to the difficult things that you might not want to hear, right? So we give feedback on a very regular basis. I don't believe in saving feedback to your semi-annual evaluations and then having you sit down in front of me and giving you something that surprises you. And so the feedback will occur in the moment on every shift. The beautiful thing, in my opinion, I'm biased, but like the beautiful thing about having residents working so closely with attendings and not necessarily like a resident run emergency department is that we're able to teach you and coach you throughout all three shifts, even when you reach a very high level of ability. And so the feedback you're going to get is going to be on shift, it's going to be after shift, it might be a phone call or a coffee date with me. And the coffee dates are not like going to the principal's office. It's like it's a good thing, right? So we talk about, what are your goals in life? How can we get you there? How can we push you outside your comfort zone? And so the feedback is a very fluid thing. The beautiful thing about a small program, again, my bias, is that trust builds very quickly. And so it's much easier to coach somebody when they trust you. They trust your intentions. They trust that the information you're giving them is based in the fact that you want them to get better. And so feedback, honestly, both ways. I expect my residents to feed things back to us and the program leadership as well. But it flows very readily both ways.
You know, talking to you and some of your faculty at ASAP, they highlighted the attending to resident ratio, and it so far it seems like the feedback must be great. You have the lower number of residents that feel like they're able to get feedback consistently and and see their progression throughout the 3 years. That's amazing.
Thing.
All right. Here's another kind of a fun one. If
Okay.
you were able to get a $1 million grant for one project in your ED, what would it be?
Oh. So funny enough, our primary site, Bethesda, is getting like a multi-million-dollar facelift right now. So I think that one is in pretty good shape. Or it will be in about a year and a half when I have like a brand new emergency department to work with. Um, I honestly think that I would like to improve. So we're in this interesting place where we're not truly inner city, right? Like we're not the Miamis of the world or anything like that, but we have a large patient population that is very much in need of external resources. So I think I would invest it in social support to kind of help with what do we do with some of these folks that we don't really want to just socially admit to the hospital because I'm not really fixing anything. We don't have social work 24/7 in the emergency department now. I have it 7 days a week, but only in the morning, or I'm sorry, only in the daytime. And let's be honest, like the most time that it's needed is after hours. And so I think I would invest it in the social support structure of a social worker in the department from 7 p.m. to 7 a.m.
That's a very interesting take. And, with all the SDOH factors that apply down here in South Florida, what a great use of that hypothetical grant. Maybe you could write one for it one day.
I know. I'll work on that. That was a good that got me motivated.
There we go. And this is a fun one that students really like to hear the answer to, just because they might be interested in pursuing fellowship. How much elective time is built into the program, and how flexible is it for students to explore subspecialties within emergency medicine?
Yeah. So we have 6 weeks built in. So you get 2 weeks your second year, 4 weeks your third year. But I'll be honest with you, I'm pretty flexible with that. Um, in terms of exploring subspecialties, so one of the things that my residents realize that I'm trying to help them figure out is whatever their and is. So it's emergency medicine and something, right? Because I want them to have long, happy careers. And it's that and that helps them kind of solidify the longevity within this specialty. And sometimes that and is subspecialty related, right? So, like, I have a lot of students and residents come through the door saying, I want to do ultrasound fellowship. And their reasoning is just because they want to be really good at ultrasound. And so we have a lot of conversations of, okay, being really good at ultrasound should happen during residency, right? You do a fellowship because you want to teach ultrasound or you want to oversee the billing and coding related to it. Um, so what we do is if I don't have it in-house and all of my core faculty are subspecialty trained in a different type of fellowship, then I bring it in-house. We have grand round speakers that come in every month. I fly them in from all over the United States. And it might just be because it was the best speaker I heard at ACEP, or it might be because I have a resident who, I'll give you an example, who wanted to do aerospace medicine and wanted to do it with NASA. And so I needed to figure out a path for her and a mentor for her. And so what we did is we found somebody who came and gave a lecture. What we do with those speakers is we take them out to dinner the night before. I'm sure you can imagine it's not hard to talk somebody into coming to South Florida for like a couple of days if I fly them down here and take them out to dinner. And so we do that and we use the time for the resident to really establish an additional mentor in that subspecialty. And then hear all about it from them the next day at the lecture of what is a day in the life of this type of subspecialty. And so we really spend a lot of time exploring subspecialties with our residents. And we really are incredibly flexible. That's the beautiful thing about not being a resident run ED is I can be incredibly flexible with my scheduling to make sure that they get to dip their toe in the pond of everything they might be interested in.
That sounds amazing. Having a good coach over there guiding you off to your next steps. That's great. Well, I like to end interviews off with this last question.
Okay.
If you could give yourself one piece of advice before starting residency, what would it be?
Um, so two things. Is it okay if I give you two? Uh,
Absolutely. No hard rules on this interview.
all right, fair. So the first one would be like enjoy my fourth year. Enjoy your fourth year of medical school, right? Like do something fun and exciting and something that I think I was like worried about spending too much money. I didn't want to travel because of the money. Like in hindsight, like I wish I spent a little bit more time in that second half of fourth year doing something fun and exciting. Um, it just is kind of going to have you reset and refill the cup before you get down to the hard work of residency. The second thing is, I would have told myself to just trust the process a little bit more. I think that we are all type A personalities and we can get a little hard on ourselves, especially during that first, 3 to 6 months of residency where you're learning so many different things, right? You might be in a new area. You're learning how to be a doctor. You're learning a computer system, where the bathroom is, how to get to the cafeteria, and you might feel like you're failing. And that feeling is going to occur often. And it's just kind of regrounding yourself to look around you, look at your seniors, look at your second years, and look at where they are and realize that, like, if you trust the process, you're going to get there too. And adding extra stress to your plate with unreasonable expectations is just going to make it harder for you.
Wow. Really eloquently and well said, Dr. Clayton. And before this interview ends, is there anything else you would like to say to the listeners?
No, other than you chose the best specialty known to man. I think that emergency medicine is truly the ability to take care of anyone, any place, anytime. And I wish you all the luck wherever you end up.